So, hi, good evening, everyone. So, here we come with the first e learning series of Neurocritical Care Society of India. So, many people are associated with the society, and we have been running our educational programs, but we have activated this channel now. So, I welcome you all for watching, viewing, and also sharing your own content. If you have some ideas, you have some videos you want to present, and you are an NCSI member, please contact us. You can write to us or you can call us personally. So we are a big team, and we are all ready to help you always. So we start with the first presentation of the day, of the session of this series. That is the Journal Club by Dr. Varun, and we also have with us Dr. Mayank Tyagi. So Dr. Mayank is the speaker for this webinar and Journal Club. And we have called this Journal Club as NCSI Bulletin. So um, welcome Dr. Varun. He is a principal consultant at Fortis Hospital, Noida. And Dr. Mayank Tyagi, he is the consultant anesthesia and neurocritical care at Fortis Hospital. So this webinar, this first NCSI bulletin, goes for the presentation of Fortis Hospital, Noida. So Dr. Varun, please start.
Yes. Thank you so much, ma'am, for giving this opportunity to start the NCSI News Bulletin. So, the topic which we have chosen for today is, can you please show that? So, the topic is with regards to the use of Tenecteplase for ischemic stroke at 4.5 to 24 hours in patients who are not able to receive thrombectomy. So, this is the TRACE 3 trials. We have chosen this trial from the New England Journal of Medicine, published last month in June 2024. So, as we know, NEGM is a very reputed journal. It has an impact factor of 96.2, and with this topic, we are trying to expand the window to improve the survival outcome and reduce the long-term disability in patients who reduce stroke. So let's see what this topic tells us about. So if Dr. Mayank is ready, I would ask Dr. Mayank to start with it.
Thank you, sir. Uh, Thank you for giving me the opportunity to speak on this topic. Uh, Good evening, everyone. So here we
Good
begin.
evening, Mayank. So we had little
Good evening,
issue
ma'am.
with the network, but I think we are
Yes,
not
ma'am.
now all prepared and pepped up. So be happy.
Yes.
There is no issue in
Ah,
delay, but let's get
yes.
on to the topic, right? No
Sorry
worries.
for the delay, everyone.
No
Uh,
problem. Yeah.
okay. So Tenecteplase for ischemic stroke at 4.5 to 24 hours without thrombectomy. This is a phase 3 investigator trial, which is published in NEGM 2024 June article, done by Zhang Y et al. By the Department of Neurology, uh, Beijing Tiantan Hospital, China. Use of IV thrombolytic agents is recommended for eligible patients within 4.5 hours after the onset of stroke. However, approximately 67 to 75% of patients present after 4.5 hours after stroke onset or within unknown time of onset. Tenecteplase is an effective thrombolytic agent for eligible patients with stroke who are treated within 4.5 hours after onset of stroke. Alteplase is beneficial when initiated up to 9 hours after the onset of stroke if perfusion imaging results indicate the presence of salvageable ischemic tissue. However, information of whether the tenecteplase confers benefit beyond 4.5 hours is limited. Am I audible to everyone?
Yes, you are audible.
Okay. Effect of late administration of tenecteplase, that is after 4.5 hours after stroke onset in patients without immediate access to thrombectomy, is currently unclear in many geographical locations, including in developed countries, and is often unavailable in low economic and middle income countries. This trial, that is the tenecteplase reperfusion therapy in acute ischemic cerebrovascular events, investigated the efficacy and safety of tenecteplase at a dose of 0.25 milligram per kg administered 4.5 to 24 hours after onset of stroke. 58 centers in China conducted this trial. multicentric prospective open label randomized trial. The inclusion criteria include the patients 18 years of age or older, evidence of large vessel occlusion of MCA, either M1 or M2 segment, or intracranial ICA on CT angio or MR angio imagings. Any evidence of salvageable brain tissue as identified on perfusion imaging, that is ischemic core volume of less than 70 ml, pre-stroke score of 0 or 1 on MRS, NHS score of 6 to 25, and patient didn't have access to EVT. Here, MRS is basically the modified ranking score, which is basically a tool to assess the degree of disability in patients who are having stroke. It is graded from 0 to 6, in which 0 is patients with no symptoms. Grade 1 is basically the patients who are having a slight disability, and 6 is basically death. So patients having a score of 0, 1, and 2 have a good score. NHS score is basically National Institute of Health stroke scale score, which is assessed from graded from 0 to 42, and around 11 parameters are assessed to have a score of 0 to 42. Exclusion criteria include patients in which endovascular thrombectomy planned at the time of randomization, guideline-based contraindication to thrombolytic agents. Patients were randomly assigned in a 1-to-1 ratio to receive tenecteplase or standard medical treatment. Randomization was stratified according to the site of vessel exclusion, ICA versus M1 or M2 segment of MCA. The assessment of the trial outcomes and events were performed by a qualified physicians dedicated committee, and all of whom were unaware of the treatment assignments. Coming on the interventions, the tenecteplase group received a bolus of IV tenecteplase over a period of 5 to 10 seconds at a dose of 0.25 milligram per kg. Maximum of 25 milligram can be given immediately after randomization. The control group received antiplatelet therapy at the discretion of the investigator. And here comes the first limitation of this trial, in which the investigator has not mentioned which antiplatelet agents were used. Coming on the outcomes, the primary outcome were the one where absence of disability, that is MRS score of 0 or 1 at 90 days. Secondary outcomes are the one where ordinal distribution of scores on MRS at 90 days. Functional independence, that is MRS score of less than equal to 2 at 90 days. Major neurological improvement at 72 hours after the treatment. Reperfusion at 24 hours after treatment, that is more than 90% reduction in the volume of the lesion, in which there had been a delayed arrival of an injector tracer agent of more than 6 seconds. The safety outcomes include those patients having symptomatic ICH, which is defined as any ICH that has either associated with an increase of more than 4 points in NHS score or led to death within 36 hours after treatment. Death from any cause, moderate or severe systemic bleeding within 90 days, and any adverse events, including any serious adverse events within 90 days. Distribution of scores on the MRS was analyzed with the use of ordinal logistic regression. Secondary and safety outcomes were reported as relative rates with respect to 95% confidence interval. Analysis of functional outcome were performed with the use of logistic regression. A total of 1469 patients underwent screening from Jan 22 through November 23, and 35% were enrolled in this trial. 264 patients were randomly assigned to receive tenecteplase, whereas 252 to receive standard medical treatment. 5.4 patients had protocol violation and were excluded from the trials. Coming on the results of this study, this table is showing the characteristics of the patient at baseline. The demographic data based on age, male sex, the comorbidities based on hypertension, diabetes, or atrial fibrillation, or modified the functional outcome based on modified ranking score before stroke based on 0 or 1, or NIHS score at randomization, And based on imaging studies, be it volume of irreversible injured ischemic core or volume of perfusion lesion at the initial imaging were similar in both the groups at baseline. The median interval between the time that the patient was last known to well and randomization was 12.3 hours. This table is showing the efficacy and safety outcomes between the two groups, and patients have a higher percentage of score of 0 or 1 on the MRS scale at 90 days in Tenecteplase group, that is around 33% in comparison to the control group with a higher relative risk of 1.37. And again, the patient have a higher percentage of score of less than equal to 2 of MRS score, indicating the functional independence at 90 days in Tenecteplase, that is 43.6%, again with a higher relative risk of 1.31. This table is showing the efficacy and safety outcome between the two groups, in which major neurological improvement at 72 hours was found to be higher in Tenecteplase group of around 16% with a relative risk of 2.66. Symptomatic intracranial hemorrhage within 36 hours after randomization was found to be higher in Tenecteplase group, that is 3% in comparison to the control group with a relative risk of 3.82. Death within 90 days was similar between the two groups, whereas moderate or severe systemic bleeding within 90 days was found to be higher in Tenecteplase group with a relative risk of 2.36. This figure is showing the distribution of scores on modified ranking scale at 90 days, and it has shown that Tenecteplase was found to have a better MRS score 0, 1, and 2 compared to the standard medical treatment. Here we can see a 13.1 and 13.3, which is MRS scale of 6, is similar between the two groups.
Ma'am, next
This
slide.
pic- Next slide, ma'am. Next slide, ma'am.
Yes.
Uh, So this figure is showing the relative rate of modified ranking scale score of 0 or 1 at 90 days, in which we can see the patients having an age of more than 80, NHS score of more than 10, or varied interval of symptoms to treatment of more than 9 hours to 24 hours have a good functional outcome in Tenecteplase group compared to that of the standard medical treatment. Coming on the discussion part, phase 3 trials showed that in patients with ischemic stroke due to large vessel occlusion who had salvageable tissue and did not have access to endovascular treatment, with IV tenecteplase between 4.5 to 24 hours after stroke onset led to a larger percentage of patients who with no disability at 90 days. Although there were no marked difference in survival at 90 days, the incidence of symptomatic ICH appeared to be higher in the tenecteplase group. Trace 3 trials and other trials provided evidence for the feasibility of this approach with the use of CT-based methods and automated softwares. Tenecteplase was shown to be non-inferior to LT-place in multiple trials in which the 0 to 4.5 window, that is within the window period, was used. I have addressed three of the major trials which are published within last 5 to 7 years. The first one was published in Lancet 2022. It was a randomized controlled trial done in Canada, and they found out that IV tenecteplase was found to be non-inferior to LT-place in comparison to functional outcome based on MRS scores. And their MRS score was found to be 36%, which was 34% in our study. Second trial was done, published in Lancet 2023. It was again a randomized controlled trial, which was done by the TRACE2 investigators, and they come out with the same interpretations. The third trial was published in Internal Journal of Stroke 2023 by the ATTEST2 investigators, and they found out that the patients having non-inferior functional outcome based on NHS or MRS scores and almost similar amount of mortality between IV thrombolysis patient undergoing with the LT-place or tenecteplase. Tenecteplase showed evidence of superiority compared to alteplase in meta-analysis of few trials. I have addressed two of them. The first one was published in Neurology Journal 2022, which was a pooled analysis of Extend 1A tenecteplase trial. And they tested the safety and efficacy of tenecteplase in older patients, basically the patients with age of more than 80 years in large vessel occlusions. Here they compared two varied doses of tenecteplase with 0.25 milligram per kg and zero point 0.4 milligram per kg with alteplase of zero point 0.9 milligram per kg. And they found out that 0.25 milligram per kg tenecteplase have a better reperfusion rate, better functional outcome based on MRS score, and almost similar mortality rate in comparison to zero point 0.4 milligram per kg tenecteplase or zero point 0.9 milligram per kg of alteplase. The second trial was published in Stroke 2021. It was a meta-analysis and systemic review between IV thrombolytic agent between the two groups in large vessel occlusion, and they come up with the same results showing tenecteplase superiority over alteplase on the basis of early reperfusion or mortality. Coming on the limitations of this study, I've already discussed few of them between the presentation. A few of them are excluded patients who had access to endovascular treatment, so the results may lack applicability to patients who present directly to the thrombectomy capable centers. This trial was performed in China, where the intracranial atherosclerosis is more prevalent than in Western countries. Effect size, although similar to that seen in thrombolytic therapy at 0 to 3 hours after stroke onset, but is similar than that seen in thrombectomy. The median ischemic core volume was relatively small, albeit larger than in previous late window thrombectomy trials. Coming on the conclusion of this trial, in this trial, involving Chinese patient with ischemic stroke due to anterior circulation large vessel occlusion who had salvageable tissue, tenecteplase administered between 4.5 to 24 hours after stroke onset resulted in less disability, similar survival as compared with standard medical treatment. And the incidence of symptomatic intracranial hemorrhage appears to be higher.
Okay, so thank you, Mike, for the nice description. So I think the conclusion basically we are what the authors are trying to say in this study is that we are looking at an option to increase the window where we can administer the anti-thrombolytic agent. So the intention is that if a patient is coming after the standard window period, which is 4.5 hours, still if we are able to administer the drug and have a better functional outcome, then it is going to reduce the morbidity and mortality which can happen because of the stroke. So authors have shown that the Tenecteplase administration has been successful in their study. It has improved the functional outcome, which is shown by the modified Rankin scale. So just we have some questions like why is Tenecteplase becoming so popular and how is it different from Altiplase?
Uh, Sir,
So can you elaborate
tenecteplase
on that?
is hello.
Yes, you're audible.
Am I okay? So tenecteplase is basically a genetically engineered variant of tissue plasminogen activator. It is fibrin-specific thrombolytic agent used to dissolve blood clots. It has three specific amino acid substitution compared to native TPA, which enhances its fibrin specificity. It its enhanced fibrin specificity reduces the systemic activation of plasminogen, which minimizes the risk of bleeding. This table is showing the difference between the two thrombolytic agents. The one is alteplase, which is basically a recombinant tissue plasminogen activator in comparison to tenecteplase, which is I've already discussed. The dosing in acute ischemic stroke in alteplase patients, they receive zero point 0.9 milligram per kg dose, followed by a bolus. They receive a 60-minute infusion, and a maximum of 90 milligram can be given. Whereas in tenecteplase, the dose varies between zero point 0.1 to zero point 0.4 milligram per kg and a maximum of 25 milligram per kg. A single bolus dose can be given. LT-Place has a short half-life of 5 minutes compared to that of LT-Place, which is 20 minutes. LT-Place shows a moderate fibrin specificity compared to that of Tenecteplase, which has a very high fibrin specificity. The major crux is LT-Place is FDA approved for acute ischemic stroke, acute MI, and acute massive pulmonary embolism, whereas Tenecteplase is still FDA approved only for thrombolysis in patients with ST-MI if PCI is unavailable or delayed. Though many developing and many developing patients are doing multiple randomized trials with Tenecteplase drugs. The based on cost effectiveness, Tenecteplase is much cheaper compared to LTplase group.
So we mean to say that Tenecteplase use is still off label. It is not FDA
Off-label,
approved.
yes. It has
Okay. So
biosimilar compound, so it is used as a off-label compound.
okay, nicely said. So can you just briefly tell us about what is the administration protocol for the thrombolytic agent which we are using at our institute?
Definitely. Whenever the patient first present to the hospital, a detailed and comprehensive history and examination should be done along with continuous hemodynamic monitoring. Thereafter, a thorough assessment, including imaging, whether it is CT or MRI, should be performed to confirm the diagnosis and rule out any contraindications. That tenecteplase is administered as a single dose with commonly used dosing of zero point 0.1 to zero point 0.4 milligram per kg with a maximum dose of 25 milligram kg can be administered over 5 to 10 seconds. Continuous monitoring of vitals, neurological status, potential adverse reactions is essential during and immediately after administration of tenecteplase. Antithrombotic agents such as aspirin or anticoagulants should be generally withheld for at least 24 hours after tenecteplase administration to reduce the risk of bleeding. Follow-up imaging is recommended 24 hours, 6 to 24 hours after the administration to assess any hemorrhagic transformations or any other adverse complications. Thorough documentation of the indication, dose, administrating time, patient response is essential for ongoing patient care for legal purposes and quality improvement. Effective
Okay.
communication is I will take one more minute, sir.
Hmm.
Effective communication with the multidisciplinary team is also crucial for optimal treatment and timely intervention for any complications. And that's it.
Okay, so here I would like to mention that the dose which we are using commonly is 0.25 milligram per kg, and most of
Yes,
the patients when they come to our emergency, the code stroke is activated, where a neurologist, neurosurgeon, and a neurointensivist they approach the patient and we take it forward. So, what are the contraindications you would like to highlight? Like before, we have to be sure before we administer any thrombolytic agents before thrombolysis.
sure. Uh, The most common contraindications include any evidence of intracranial hemorrhage on imaging, any history of intracranial or intraspinal surgery within the past 3 months, severe uncontrolled hypertension that at the time of treatment, that is systolic blood pressure of more than 185 or diastolic blood pressure of more than 110 mmHg, any active internal bleeding or condition that increase the risk of bleeding, known bleeding disorders or condition that predispose to bleeding. Apart from that, any history of stroke or serious head trauma within the past 3 months, recent gastrointestinal or genitourinary bleeding within last 21 days, any history of recent arterial puncture at a non-compressible site within the last past 1 week, seizure at the time of onset, which could indicate a different etiology. Known hypersensitivity to tenecteplase or any component of the formulation, and last being the undergone any major surgery within the past 2 weeks.
Yes, rightly said. Uh, Besides these, the use of NOACs is quite rampant in recent time. And so, if the patient is on NOACs, that is newer oral anticoagulants, then again the use of thrombolytic agent is not preferred. Besides this, we also get the PT-INR done, and if the INR is more than 1.7, especially patients who are on warfarin or on acetron, then again we do not use altiplase or tenecteplase for that matter. Okay, so once we have administered these agents, what monitoring would you like to use?
So,
What are the parameters we should
uh,
assess once we have administered the thrombolytic agents?
so once the patient is received in the ER department, we perform a thorough baseline assessment, be it vital signs, neurological status based on NIHS score or the baseline laboratory test. Establishing a baseline always help in detecting or any changes or early complications. So practicing continuous monitoring during administration for immediate detection of adverse events such as hypotension, allergic reaction is critical for prompt treatment. We perform frequent neurological assessment using the NHS score or GCS, and early detection of neurological deterioration can indicate complications such as intracranial hemorrhage or stroke progression. We need to maintain the blood pressure below 185 and 110 mmHg during and after administration. We can use antihypertensive medications to control the BP, and we monitor for any bleeding or sudden deterioration in the patient status. We perform a follow-up CT or MRI imaging within 6 to 4 hours after tenecteplase administration, and continuous cardiac monitoring need to be done to detect any arrhythmias in such patients who already have a cardiac history.
Okay, so blood pressure target is usually 180 to 110 millimeters of mercury. We have to keep it below that. And post-op
Yes.
imaging, we prefer it between 4 to 6 hours and at 24 hours. Okay, so what are the adverse events which can happen? Why are we so worried about? And what are we
Mhm.
expecting?
The most common adverse event related to this drug is chances of having an intracranial hemorrhage. If we look out the studies in the last 15 years, we found out that major of the trials in meta-analysis have quoted around 3 to 4.5% of chances having intracranial hemorrhage. Apart from that, patient may have systemic bleeding, any allergic reactions. Hypotension is common in such patients, and the chances of reperfusion I have already discussed in the previous slides, and the chances of having injection site reactions. And apart from that, the patient may also present with minor bleeding like gingival or pulpal bleeding.
Okay, so nicely presented. So we have covered a lot about interplays and the trials. So are there few more trials you would like the listeners to know just in case, which are related to the use of interplays and which has happened in the recent past?
Sure, sir. I have quoted some of the trials in my slide. I think everyone can see that. And
Yes.
most in majority of the trials, whether it is meta-analysis, systemic review, or randomized control trials, majority of them are performed in the past 15 years, and they were done on the basis of chances having early or higher perfusion, chances of having a similar mortality, or functional outcome based on the NIHS score or MRS, and patients having efficacy, particularly in late window period, particularly in patients having a better perfusion imaging. So these are the trials who were tested, who were done in last 15 years, and they found out that tenecteplase have a better rate of functional outcome, similar rate of mortality, and it can be given in late window period who have better perfusion scanning in compared to those with LT plays. This Tempo 1 trial is done in published into Stroke 2012. A similar trial has been ongoing, which was started in 2020. This is Tempo 2 trial, and the results are still pending. Extend 1A and Extend 1A Tenecteplase Part 2 is published in 2018 and 2021. This is particularly in patients with late window period who are undergoing endovascular thrombectomy, and they found out that the patients have a better outcome in comparison to LT-Plays. And Tenecteplase S2P is published in Stroke 2010, and they shown that this is particularly done for recanalization of patients who are having a basal artery occlusion. And they found out that Tenecteplase is superior to LT-Plaze for early perfusion or higher perfusion rates.
Okay. Okay. So nicely done. I think we come to our end of the general club, and from nicely presented, Dr. Mayan. And
Thank
so
you so much,
we
sir.
have some take-home messages for our listeners. So basically, the use of mechanical thrombectomy is not readily available. Even in developed countries, there may not be enough centers for patients to be available at thrombectomy capable center at the right time and to be given opportunity for improved survival. Therefore, we are looking at opportunity to expand our window where we can increase the thrombolysis. So first thing which comes to our mind is we have to make a diagnosis. So diagnosis, CT and MRI, both modalities are available, but CT based modality, especially CT perfusion imaging, they can be used readily because it is better available. It can be easily set up. They have a faster separation and imaging time, and therefore we can proceed for thrombolysis at a faster rate. And coming to the next slide, which shows that the use of Tenecteplase has become more and more readily. I mean, Tenecteplase is being used more readily in the recent time. The advantage being it can be given as a single bolus, unlike antiplase, which needs infusion. And so here, the authors have shown that administration of Tenecteplase, even after late hours, 4.5 hours of stroke window, has shown improved survival, and this may be especially beneficial in places of low income or middle income countries. However, we need to be careful, like it is still something in progress, and this study was conducted only in China. So, in places, as Dr. Mang has already mentioned, where intracranial thrombosis is more common, unlike the large vessel occlusion. So let's see what the future beholds for us, and hopefully we'll be able to save more patients who can have a better survival outcome, even if they are coming outside our standard thrombolysis time, that is 4.5 hours. Thank you so much, and I hand over to Ashish ma'am for any questions and comments.
So I could not see the chat. I any messages, and you are welcome to drop your messages. We will have an active watch on our YouTube channel. So if you have any messages for questions or messages for us, do drop in. And this with this we come to the end of the first bulletin. Thank you very much for a patient hearing. Thanks.
Thank you so much. Thank you.
Thank you so much.
So thank you, Varun. Thank you, Mayank. And special thanks to Dr. Jayant, Dr. Rohini, and our statistical advisor, Dr. Neeraj. Thank you so much.
Thank you.
Thank you. Thank you so much.